Good afternoon and bonjour à toutes et à tous. As usual, I will start with the latest numbers on COVID-19 in Canada. There are now 50,373 confirmed cases, including 2,904 deaths. To date, labs across Canada have tested over 758,000 people for COVID-19, with about 7% of these testing positive. Yesterday, we had an update on the progress that Canadians have made in flattening the curve of COVID-19. We also looked at some of the short-term predictions from our real data forecasting models. Things are looking better, though we're not entirely out of the woods yet. We have to remain mindful that our projections are only as reliable as our actions, now and going forward. If we maintain measures that keep the growth rate down and prevent a rebound, we stand the best chance of remaining on this favorable trajectory. With these promising signs, we are increasingly hearing of reopening plans, but this won't happen at the same time or in the same way everywhere. We've seen that the epidemiological picture in Canada, with slowed growth and bending of the epidemic curve, is actually a composite of very different regional outbreaks and different drivers of COVID-19 spread, depending on where you are in the country. Some areas are seeing very few or no recent cases and have started their gradual social and economic reopening. At the same time, all areas of the country know that there is still a need for key public health practices, like physical distancing when we are out or in the workplace and good hand washing, always. The ability to maintain these preventive practices is an important part of reopening plans for workplaces, schools, and businesses. Other critical public health capacity that must be in place and maintained across Canada is necessary to ensure adequate testing to detect alerts and respond quickly to any new disease activity. Local, provincial, and territorial level plans for reopening are key to managing this next phase. These plans are based on public health criteria and balance the effectiveness of public health measures against their potential negative consequences. Likewise, these measures will need to remain flexible and adaptable to alerts and signals. Although we will be living with COVID-19 for the foreseeable future, we also know that together we can keep this virus at bay by remaining vigilant. Our collective efforts have already slowed the growth of COVID-19, bent the curve, and enabled our health system to cope. These are no small feats, and they tell us we will get through this. Ça va bien aller. Thank you. Merci.
Bonjour. Comme d'habitude, commençons par les derniers chiffres sur la COVID-19 au Canada. Aujourd'hui, il y a 50 373 cas confirmés, dont 2 904 décès. À ce jour, les laboratoires de partout au pays ont effectué plus de 758 000 tests de dépistage et environ 7% d'entre eux se sont avérés positifs. Hier, nous avons fait le point sur les mesures dans lesquelles les Canadiens ont aplati la courbe de la COVID-19. Nous nous sommes également penchés sur certaines prédictions à court terme tirées de nos modèles de prévision fondés sur les données réelles. La situation s'améliore, bien que nous ne soyons pas encore entièrement tirés d'affaire. Il faut se rappeler que la fiabilité de nos projections est directement proportionnelle à nos actions, présentes et futures. Si nous continuons de prendre les mesures qui limitent le rythme de croissance de la maladie et qui préviennent une remontée, nous maximisons les chances de suivre cette trajectoire favorable. Avec ces perspectives encourageantes, nous entendons de plus en plus parler des plans de reprise des activités. Cette reprise ne se déroulera pas au même moment, ni de la même façon partout. Nous savons qu'avec les efforts de ralentissement de la propagation et d'écrasement de la courbe, le profil épidémiologique au Canada est composé d'éclosions et de facteurs de propagation qui varient grandement d'une région à l'autre du pays. À certains endroits, le nombre de nouveaux cas est très peu élevé ou nul et des plans de reprise des activités sociales et économiques sont progressivement mis en œuvre. Parallèlement, dans toutes les régions du pays, les gens sont conscients qu'il faut maintenir les mesures de santé publique clés, comme l'éloignement physique, comme nous sommes à l'extérieur et au travail, et bien se laver les mains en tout le temps. Le maintien de ces mesures préventives est un aspect important des plans de reprise des activités dans les lieux de travail, les écoles et les entreprises. Il faut aussi assurer une capacité essentielle en santé publique dans l'ensemble du Canada afin de pouvoir procéder adéquatement aux tests de dépistage qui permettront de détecter tout nouveau signe de propagation de la maladie et d'y réagir rapidement. Les plans locaux, provinciaux et territoriaux pour la reprise des activités sont au cœur de la gestion de cette nouvelle étape. Ces plans sont établis en fonction des critères de santé publique et visent un équilibre entre l'efficacité des mesures de santé publique et leurs conséquences négatives potentielles. De même, ces mesures devront être souples et pouvoir être adaptées face à des alertes ou à des signes de propagation. Bien que, dans un avenir prévisible, nous devrons vivre avec le COVID-19, nous savons qu'ensemble, nous pouvons tenir le virus à distance en demeurant vigilants. Les efforts déployés collectivement ont déjà ralenti la propagation de la COVID-19, aplati la courbe et permis à notre système de santé de gérer la crise. Ces réalisations sont remarquables et nous montrent que nous en sortirons. Ça va bien aller. Merci.
Thank you, doctors. We will now open the line to questions. Vous pouvez poser vos questions dans l'une des deux langues officielles. We ask that you limit yourself to one question and only one follow-up. For those asking a question in the room, we do ask that you make your way over to the freestanding mics. Operator, over to you.
Thank you. Merci. Please press star 1 at this time if you have a question. Veuillez appuyer sur étoile 1 maintenant pour poser une question. Notre première question est de Brigitte Bureau de Radio-Canada. À vous la parole. Please go ahead.
Oui, bonjour, Mrs. Tam. We have found many scientific studies done after SARS and H1N1 that state that the wearing of mask, procedure, or surgery in the community is one of the best measures to reduce the spread of respiratory viruses. Is the shortage of those masks the reason that you first did not recommend that the Canadian population should be wearing them?
So we're always evaluating information and data as we have it. Previous studies that have really been based on influenza studies, for example, there wasn't a huge amount of data. However, we had extensive discussions with Chief Medical Officers of Health and recognized that we do want to make sure medical masks are reserved for our healthcare workers. We also want to be absolutely certain that the public knows that all the other measures that we recommended, it still needs to be observed, including those personal hygienic measures, washing your hands, and staying home if you're sick, and keeping that physical distance from others is the most effective way for reducing transmission. But then we felt that as we examined the information, especially given further data on the fact that we have pre-symptomatic and asymptomatic cases that could potentially transmit, at that point in time, we felt that the public in general can consider wearing a homemade mask or facial covering when they can't maintain that physical distance. I have to say that we're ongoingly re-examining that information, and we will, of course, provide an updated recommendation as we get those discussions underway. Thank you.
And one follow-up?
Yes, I recognize, Mrs. Tam, that we were also in an emergency situation, but in hindsight, do you believe it would have been a more precise message to the Canadian people to say that, yes, masks do work with other, medical masks do work with other measures, but because we have a shortage, for now, we should make sure that they go to the health professionals? Would that have been a more precise message in hindsight?
I think that given the evolving data, we knew that the message had to undergo evolution, and that at that point in time, that's where our message was. The chief medical officers felt that we absolutely have to stick with the physical distancing and other measures. This offers another layer of protection from you transmitting the virus to others and not from you necessarily acquiring, doesn't prevent you from acquiring the virus yourself. So that was also a very important message that we wanted to put out. And so for that point in time, that was felt to be appropriate by the chief medical officers. And again, we're re-examining that data as we speak.
Yeah,
Thank you.
Dr. Njoo, just to add to what Dr. Tam has said, most of the evidence we've had to date, as she's mentioned previously, was based on our knowledge of other respiratory infections, primarily influenza, and how that spread in terms of what masks may or may not be able to do in terms of protection and so on. Certainly with this virus, we're learning that it's not exactly like influenza. It's an infection and a virus that has its own unique sort of qualities and aspects, and that's why we're still accumulating the scientific evidence, and certainly it evolves. And as Dr. Tam has mentioned, I've said as well, the newest type of evidence we're learning about is potentially transmission for people who we call maybe pre-symptomatic, post-symptomatic, having few symptoms, or asymptomatic. And that's why the advice has and the evidence has led us to modify, obviously, as we go along. We're still learning a lot about the virus, and we will continue to be learning.
Thank you. Operator, next question on the line.
Our next question is from Mary Kay Walsh from the Globe and Mail. Please go ahead. À vous la parole.
Hi, doctors. I'm wondering if you can confirm the Imperial College London assumptions that you released as part of the model yesterday. Are those assumptions that are tailored specifically to Canada, or are those a more generic assumption for the entire world or for another country or region?
So they were tailored to the Canadian context, but of course take into account international data sets. Because as knowledge, these are dynamic disease models, so you have to sort of look at the knowledge as they grow. And when you look at the behavior of a virus, includes a whole range of parameters which change over time. So I think those can be adapted, but it's a methodology, I think, that was involved. But it's, again, as we said, is only one method as well. You have to sort of look at different models in multiple ways to come up with a tool that you can use. And that's one of the tools that we use to estimate 3 different planning scenarios.
And follow-up?
Okay. Yeah. So just to clarify, did your officials tailor the model to Canada, or did the college do that for your agency? And why hasn't the agency conducted its own sort of random sample test of COVID in the Canadian population, so that when we are looking at reopening the economy, we have a better idea of what the disease actually looks like in the general population?
That is exactly the right question. I think that's why there was the formation of the Immunity Task Force, because we know that reported cases is the tip of the iceberg. So the concept is that we would look at antibodies in the population, and the task force work is going to inform how that would be done in the most appropriate and effective way possible. And so we will get some of that information in the next months. I think the other thing is that the serologic assays are still being reviewed in terms of their how well they perform. So that also has to come together, as well as the fact that we have limited knowledge about the immune response to this virus in the population. And so we do not know, while antibody response does occur, how long they last for, how effective that is. And so all of the work is underway, but that will show us more about the underlying overall population that is infected. So that will actually come along. And I think absolutely the agency, together with quite a major group of network of modelers across the country, looks at the different assumptions. They are updated every week, and they calibrate their models accordingly for planning purposes. This happens to be a model that can still work. I mean, you're looking at quite a broad range of attack rates with the epidemic controls, with weaker controls, and with no controls. Those ranges, so they're still relevant for planning purposes.
Thank you. Operator, next question on the line.
Thank you. Our next question is from Lina Dip from La Presse canadienne. À vous la parole, please go ahead.
Dr. Njoo, je voulais savoir, un des critères sur lesquels Ottawa et les provinces s'entendent là, pour le déconfinement, c'est la capacité de faire du retraçage et de la surveillance des quarantaines imposées à certaines personnes. Je voulais savoir quelle est votre évaluation en ce moment de la capacité de retraçage au pays et surtout de la capacité de surveillance des mises en quarantaine. Et est-ce que vous voyez la possibilité de géolocalisation, par exemple, des téléphones comme un outil utile à la santé publique pour surveiller les mises en quarantaine?
Merci pour les questions, et ce sont des bonnes questions. Premièrement, ce que je peux dire, c'est moi, Dr. Tam, on continue à travailler étroitement avec nos homologues, incluant Dr. Arruda de Québec, et on peut dire que dans la communauté des médecins hygiénistes, des spécialistes de santé publique, on est tous sur la même page. Donc, avec les critères pour peut-être déconfinement, c'est sûr que le Québec et les autorités là ont plus de données que nous autres ici à l'échelle nationale. Et c'est vraiment à eux à utiliser l'analyse épidémiologique au fur et à mesure pour examiner c'est quoi les options et considérer peut-être qu'est-ce qu'on veut faire au Québec concernant quelques secteurs. C'est sûr, il faut avoir une bonne capacité pour dépister, isoler, diagnostiquer les cas et aussi faire un retraçage des contacts. Avec ce qu'on voit au Québec actuellement, avec la capacité des laboratoires, qu'est-ce qui se passe à travers la province. Nous autres ici, ce qu'on voit ici de côté fédéral, on voit que le Québec a une bonne capacité et c'est sûr que c'est toujours quelque chose qu'on peut toujours améliorer partout au Canada. Donc, je pense que ça, c'est en place. Deuxième, peut-être aussi pour ajouter à ça, je pense qu'au Québec, je pense que j'ai dit ça hier, que pour le Québec, c'est vraiment, je pense qu'il y a trois choses à considérer. C'est sûr qu'il y a vraiment une situation spéciale. Malheureusement, c'est tragique. Qu'est-ce qui se passe actuellement dans les établissements de soins de longue durée? Donc, c'est quelque chose, il faut continuer à gérer bien, dépister, aussi faire le suivi. Qu'est-ce qu'il faut, c'est nécessaire dans ces établissements. Mais si on parle de reste de la province, c'est intéressant parce qu'on sait que ce n'est pas la même situation à travers la province. C'est sûr que le Montréal, c'est un foyer. Et qu'est-ce qui se passe actuellement à Montréal? Ce n'est pas la même chose peut-être que si on parle de la Saguenay et Lac-Saint-Jean. Donc, je pense qu'au fur et à mesure, c'est aussi quelque chose à considérer si on veut faire peut-être les étapes des confinements. Peut-être qu'est-ce qui se passe, on veut faire quelque chose à Montréal. Peut-être le rythme, le calendrier, peut-être c'est un peu différent comparé aux autres régions de la province. L'autre question, je pense que c'est avec les outils. Je pense que ici au Canada, à travers les pays, il y a beaucoup de gens qui s'intéressent. C'est quoi les options pour les outils peut-être utilisés pour le retraçage des contacts? Et c'est sûr, avec la technologie, il y a beaucoup de possibilités. Et on est en train, je pense, il y a même un groupe avec les représentants de toutes les provinces et territoires, aussi avec nous autres ici du gouvernement fédéral. On examine c'est quoi les potentiels des apps et on considère toujours actuellement c'est quoi les options. Mais on sait qu'il y a toujours un équilibre entre les buts, les objectifs de vraiment protéger et garder la santé publique, mais aussi pour garder la confidentialité, aussi la vie privée des personnes dans toutes les provinces et territoires. Mais c'est un enjeu actif et on continue de travailler. Est-ce que j'ai répondu à toutes les questions? J'ai oublié.
Oui, elle a une suite.
Oui, absolument.
Okay.
Absolument, merci. Ma question de suivi peut-être to you, Dr. Tam, because yes, Dr. Njoo answered almost everything, but but not my very first, very specific question. I just want to know what is your assessment right now of the capacity in different provinces to retrace and also to watch over quarantine people. What is your assessment now? Are they doing it well? Not enough? Too much? Are they being able, all of them, to retrace and to watch over the people put in quarantine?
I think, again, as Dr. Njoo said, we work very closely with the Chief Medical Officer. We, again, together look at the criteria and make sure that, one of them is, of course, case detection and contact tracing. I think everyone is looking at their testing capacity, and that is increasing as we speak. We are now looking at, in the next phase, what will be the appropriate thing in terms of expanding testing as well. At the moment, in some jurisdictions, they actually have overcapacity and they don't actually have many people coming up for testing because I think some of the respiratory season is over, and so they actually do have capacity to test for more. And so we're looking at, how do we best go into the next stage as provinces look at their sort of living with COVID, that next phase. So that is actively under discussion. But I think all of us really feel that we have to all increase laboratory testing in general. And some of it is also linked to the fact that we're trying to get as much supply as possible. So all of these pieces are linked to enhancing capacity in the provinces. But I think that all would agree that unless they have those pieces in place, they would be extremely precautionary about reopening or easing any public health measure.
I'm sorry, but my question was not about testing at all. My question was about surveillance of quarantine.
Sorry, Lynn. Go ahead.
I was not asking about testing.
Yes, so you have, in order to detect cases, it's part of the process is actually testing for cases and then looking at the context. So based on all of our discussion of provinces, they have the contact tracing capacities, and we have offered to support where they cannot, and including those who have applied to be volunteering in the federal roster that provinces can tap into. So we are developing a surge capacity to make sure that if more contact tracers, for example, are needed, that they can be accessed.
It's Dr. Njoo, just adding to what Dr. Tam said. If your question is about sort of people in isolation, quarantine that provincial authorities have put under, certainly the feedback and the discussions Dr. Tam and I've had with our counterparts, there have been no issues of public health and so on. It's certainly been monitoring people, in quarantine isolation, and there's been, I think, generally across the country, a good, I would say, compliance. People understand the importance that if you are in quarantine, that you're not only protecting your health, but protecting the health of others. And so I think, by and large, everything is going well in that regard. Thank you.
Thank you. We'll now come to the room for a question. Ryan?
Dr. Tam, the provinces have released data on their cases, how many they suspect are from travel, and then also dialed it down to where they expect that travel was from. And despite the focus on it, very, very few of the cases in the country are from China, where we first closed our flights to, and most of the cases are actually from the U.S. I'm wondering if you think the way we closed our borders to international travelers was maybe backwards, given that so few of the cases are from China.
Well, I think as the pandemic evolved and we understood where the epidemiology is, I think the public health measures have been added as a result of the knowledge at the time. So, but we knew at the beginning it was more focused on China, but they were containing at the same time. So we instituted the enhanced screening, focus on initially China, and then as it moved into Europe and Iran. Those were the initial places. But of course, this virus had, in fact, rapidly, I think, spread to Europe, being the next epicenter, and the United States. So in March, we, in very quick succession, first of all, told people not to go on cruises, issued a sort of global travel health notice, because you can't actually tell which country, in fact, the virus could come from, followed by the succession of border measures. And so I think the border measures in terms of other countries, including Europe, followed by the United States. That's how they sequenced it. But I think the implementation of such an incredible sort of policy takes many departments a lot of thinking, but for sure we've been monitoring together with the provinces where the travelers have come from. But I think things actually revolved really, really rapidly, I think, is what was going on. And we were just layering on the border measures as we got the information.
And
but you're right, and we only got, I think, in total about 8 to 10 travelers that were initially linked to China or travel to China or linked to travel to China, and then followed by Iran, where they hadn't actually really reported cases, and they were already being picked up in Canada, followed by other areas of Europe, and then the United States.
And then just as a follow-up, do you have a sense in terms of those travelers if most of them were Canadians coming home as opposed to tourists or business travel? Canadians who would have been allowed into the country regardless of what restrictions might have been in place?
I think we will have to get back to you on the beginning, but of course, at a certain point, we actually did not allow non-Canadians or permanent residents to travel to Canada. So prior to that, though, there would have been some travelers who were probably not Canadians, who were here, some of them for to visit or for travel purposes. But those really, actually diminished very, very rapidly, not just because of the actions in Canada, but all over the world in terms of the travel volume going down, the flights not flying. So there's lots of different, I think, aspects to the dynamics in terms of travelers.
Yeah, I can add to that. It's interesting. My own sort of personal recollection in terms of the first cases coming to Canada that were linked to travel from China were actually Canadians or certainly residents of Canada who were coming back. And so what I think is also interesting to add to what Dr. Tam said is that if you look at the border measures we put in initially in terms of the screening, the enhanced screening we had for people coming from China, I think by and large it worked in terms of that specific focus because quite quickly after that, the number of cases linked to travel from China dropped off. But the issue then is that, well, someone says, well, why didn't you close all the borders? And you can imagine in February, would we have closed our borders to the U.S. and every other country? The world is so interconnected with travel from all points, from one country to another. And as Dr. Tam mentioned, what happened then afterwards is that we started noticing cases that were linked to travel from Iran, from Italy. And so that was also our clue that, hey, the world's interconnected and really the virus is spreading throughout. And so it was obviously a serious decision when we, quote, close our borders except for non-essential travel to the U.S. So the other part also I think that we've said previously is that if you look at border measures, they're only one measure. They're only sort of one layer in terms of a multi-system, a sort of multi-layered approach. And really, the most important part is not what happens at the border. It may be an opportunity to educate travelers of what they should be looking for in terms of symptoms, but really it's a good integrated public health and healthcare system. The fact that we have the system that still works well today to be able to detect cases rapidly, treat them, isolate them, do the contact tracing, have the laboratory testing. That's been key. And you can see that our system worked well because we were basically the first country to detect cases before they were even reported in those countries, for example, Iran.
Thank you. We'll come to the next question in the room. Julie?
Julie Van Dusen, CBC. For Dr. Tam, Quebec says it's going to open schools and daycares on May 11th, and considering it's got the highest rate of COVID-19 and highest number of deaths in the country, do you have any concerns about this?
I think, as I've said, that we, together with all chief medical officers, including Quebec, came out with the necessary criteria. You saw that in the statement made by our first ministers, that we all support those criteria, including the fact that transmission is controlled and capacity is in place to detect and isolate. I think all of us have the exact same approach in that we need to be extremely cautious as we come down the other side of that curve. And I think all medical officers, provincial, local, are very much in line with that. They're also trying to look at their own context and balancing out the benefits, but also the potential negative effects, whether it's mental health or otherwise. And they will look at how they cautiously do any of these relaxations, including schools. So, I mean, it's best to discuss, of course, for Quebec, but as I understand it, they're not looking at Montreal. They're looking at elsewhere first. And the epidemiology is different in different parts of Quebec as well.
And one follow-up?
Kind of, but my next question is, I guess for Dr. Tam, considering that Canadians are not going to work, they're staying at home, they're staying 2 meters apart, they're washing their hands, and they're not getting on airplanes, how are they getting the infection then? How is it that COVID is still spreading?
So they could be in multiple ways. Not everybody is staying home. Obviously, if you had symptoms, if you're a case, if you're asked to self-isolate, you absolutely must stay at home. You know, the vast majority of cases, the epidemiology is quite different in different places. Some people are going to work. Essential services are being maintained. Some of these essential services, unfortunately, are healthcare settings, including long-term care. And they have workers who work there who are linked to the community. So there may be a number of different pathways at which the virus could spread. And that's why you have to be really, really cautious. But provinces are also looking at whether their cases are linked to specific clusters versus cases that are not linked and that are still in the community. That's a very important part of the assessment as they look at that next phase. They do not want to see a lot of these unlinked cases where you can't trace where they're actually coming from. So that's part of that criteria and the epidemiologic assessment.
Okay, next question, Kelsey.
Thank you for taking my question. I think it may have been partially answered in French by Dr. Njoo, but if I could ask it in English to Dr. Tam. It's my understanding one of the needed elements of getting Canadians back to work is more tracing of the coronavirus, either by people or digitally. So I'm wondering if you agree with this, and do you think automated digital tracing would be a useful tool?
I think Dr. Njoo did touch upon this. It is something that is of interest in a number of the provinces and territories. So we're actually pulling groups together to see what the interests are or the demand might be. I think people have heard that other countries might have used this to good effect, but this is Canada. We need to know that this is appropriate for our setting. And some of the considerations of paramount importance, of course, is privacy. So I think all of that will be taken into account as jurisdictions are looking at the tools, but they are actually quite interested in some of them. And so that's why we're trying to get people together to actually examine a range of them.
Okay, so then as a follow-up, given the interest, I'm wondering, will Health Canada or the Public Health Agency draw up a list of guidelines for what the digital tracing apps must measure For example, will the apps need to measure not only a contact between individuals, but also how long they're in contact?
I think all of those discussions are currently taking place. So I think it depends on what the needs might be as we examine those apps.
Thank you. We're going to go back onto the line for 2 questions and then come back to the room. Operator, over to you.
Thank you. Our next question is from Stephanie Levitz from the Canadian Press. Please go ahead. À vous la parole.
Good afternoon. It's a question for Dr. Tam. I wanted to ask you about the science behind coronavirus, which is to say that in recent days there have been reports coming out that COVID-19 could be responsible for serious blood clots, strokes, and then I guess in the UK, Kawasaki disease in children. So what's the science telling us in Canada about whether or not this virus is more than just a respiratory virus? And does that change the risk factors in any way when it comes to looking at distancing restrictions for children?
Yes, so I think that the scientific literature is being shared globally, including any observations from the UK. I think that in addition to the response to the virus, it also has been observed that some people have more of the immunological reaction or inflammatory response. So, but we do know the risk factors are still related to your age. So if you are over the age of 60, you're much more likely to be hospitalized, and that the deaths occurring in those primarily also over 60, like over 95%, I think, are our deaths, or actually more than that. So serious illnesses can occur, hospitalizations can occur in younger age groups, but they are less likely. But no age group is necessarily spared in terms of being infected. Pediatrics is a very important area that we need to pay attention to. Children, particularly those under the age of 10, tend to have a very mild clinical course, and it appears that they may not be transmitted, the key transmitters in the drive of this epidemic. But coming back to some of these observations, including some of these inflammatory reactions, we are in very direct contact with our Canadian pediatric networks. So through the Canadian Pediatric Society and the Canadian Pediatric Surveillance Program, they have been monitoring, for example, these sort of frostbite-like rashes on kids' toes, for example, or fingers. We've also connected with them about this observation from the UK. In fact, very little is known about this observation in the UK. It was just a general alert to their clinicians. They do not know whether it's linked to coronavirus or not. But viral infections in general, though, do result in some of these observations. But just to, message to all the parents in Canada, the cases observed in Canada have been generally mild, and your pediatricians are in very close contact with each other. And so if you're concerned about anything at all, please do reach out to your family practitioner or your pediatrician. They are absolutely they're connected across the country and sharing information.
Thank you. And one follow-up, Stephanie?
Yeah, thanks for that. For the follow-up, I want to go back to a bit of the modeling information you released yesterday when you talked about the goal of viral transmission and how you wanted to sort of see it below this idea of one person infects less than one other person, and then eventually the epidemic dies out. Should a standard like that not be attached to provincial reopening guidelines? There's no scientific benchmarks, it appears, being used as provinces decide to reopen. Should there be?
Yes, so with the chief medical officers, we are looking at the indicators that are linked to each of those criteria. So right now, and some of the consideration does include that kind of parameter, but it is not a singular indicator. So what we discussed was the fact that these kind of decisions are very important decisions, and they're quite complex. You have to look at all the different criteria and the measures or the indicators kind of at the same time. And no one indicator might necessarily trump another indicator because it's quite a complex decision, and you're weighing out the effectiveness of the measure potentially against any negative impacts, social, economically, or otherwise. So it's not a simple kind of equation where that you just look at a single number. But absolutely, the reproduction number, or the R, or what we call the effective reproduction number, is one element of that assessment.
Thank you, operator. Next question on the line.
Thank you. Our next question, notre prochaine question est de Christine Laflamme de Radio-Canada. À vous la parole.
Oui, bonjour. J'aimerais revenir sur l'utilisation des applications mobiles pour aider au retraçage des contacts. Le premier ministre dit toujours qu'il va se fier au conseil des scientifiques. Alors, vous conseillez le premier ministre, quand vous regardez cet élément-là, est-ce que vous jugez que ça pourrait être un bon outil ou qu'est-ce que vous pensez de cet outil si on arrive à bien contrôler peut-être les critères là, de vie privée qui inquiètent un peu tout le monde?
Merci pour la question, c'est Dr. Njoo. Oui, nous autres, Dr. Tam et moi, on donne toujours une perspective de la santé publique et nos conseils, c'est toujours basé sur la science et les données probantes. Concernant les outils, les apps, peut-être sur comme des smartphones, c'est quelque chose, on examine, on sait que c'est quoi les enjeux, mais pour nous autres, c'est vraiment ciblé sur c'est quoi les objectifs pour la santé publique. C'est sûr, si on veut avoir la meilleure efficacité, on peut dire, pour retraçage des contacts, il y a toutes sortes de possibilités. Mais on sait aussi qu'il y a des autres considérations. Et on sait qu'on travaille étroitement aussi avec nos experts des éthiques, des autres domaines. C'est pas seulement la science et santé publique qui c'est important, ils font partie de la conversation, discussion. En fin de compte, c'est vraiment une décision pour les décideurs et Dr. Tam et moi, on donne seulement les conseils basés sur la science et la santé publique. Merci.
Mais Dr. Njoo, est-ce que pour vous, à vos yeux, c'est un bon outil? Ou sinon, s'il faut se tourner vers le téléphone et les bénévoles pour suivre les contacts, est-ce qu'on va rater peut-être l'occasion de mieux contrôler la contamination? Moi, je veux savoir qu'est-ce que vous en pensez.
OK, c'est intéressant parce que moi, j'ai une côté, OK, si je porte mon chapeau comme professionnel de santé publique, mais moi, je suis aussi comme un individuel, une personne comme tout le reste de la population canadienne. Donc, moi, je peux comprendre c'est quoi les objectifs de santé publique, si on veut vraiment avoir les meilleurs moyens pour vraiment trouver absolument tous les cas, tous les contacts, faire un bon suivi, faire ce qui est nécessaire, vraiment seulement penser avec les objectifs de santé publique. Oui, oui, c'est intéressant. Qu'est-ce qui est possible avec les outils? Mais moi aussi, comme un Canadien, un citoyen, moi aussi, c'est wow. Est-ce que c'est quelque chose? Moi, j'ai aussi une vie privée. Je respecte aussi la confidentialité aussi pour moi-même. Donc, c'est aussi un autre aspect. Heureusement pour moi, je donne seulement c'est quoi les options, c'est quoi les sciences, qu'est-ce qu'il faut considérer de côté de la santé publique. Mais moi, je sais aussi, c'est pas seulement la science et la santé publique qui en font partie des considérations totales pour peut-être prendre une décision finale.
Thank you. We'll now come back to the room for a question. Molly.
Hi, doctors. Molly Thomas, CTV National News. Thanks for taking our questions. If most cases today are coming from care homes, hospitals, and food facilities, does this suggest we have a hygiene and health policy failure in these institutions?
So I think, sadly, I think this virus has pointed out some of the areas that we need to do better at. And I think how we support our seniors, the long-term care homes, or other areas where they live needs to improve. And I think people are trying very hard now to make sure that infection prevention control protocols are in place, and so that's absolutely an area that one of the criteria that we have is supports in place for vulnerable groups, communities, and key populations, and those are exactly the kind of populations we're looking at. But also workplaces need to have good plans if they are to continue or they are to think about reopening and according to public health advice. So I think the other populations that we are most concerned about also includes those in correctional facilities, those who are experiencing homelessness, and those who might also be living in what we call congregate settings, where it's more of a crowded condition as well. And so I think in line with this sort of next phase, we need to do better in each of those kind of settings.
Dr. Tam, the Canadian Football League is asking the government for a bailout right now. On the medical side of things, do you think we'll be able to sit side by side in an arena of 30,000 people within the next year? Or is this the end of sports leagues as we know it?
For the next while, I cannot see a single chief medical officer of health across this country who's going to say that these mass gatherings are going to be there. Of course, we'll evaluate things as we're going along, month by month. But when we say we're easing into it, that's definitely not easing into it. So mass gatherings will not be part of our lives for a while.
Thank you. Next question in the room, Tonda.
Good morning, Tonda McCharles, Toronto Star. Dr. Tam, Dr. Njoo just said that, your job is to offer the scientific advice on the use of these contact tracing apps. And you and the Prime Minister today have talked about looking at lots of options. Can you tell me what is the science advice on whether the digital tracing apps actually are superlative to efforts by humans to phone people?
Yeah, and that's why I think it has to come from the people on the front lines who have to do contact tracing, because I am actually working from a bit far from the sort of front line and what will be helpful to them actually. And so I think people see these technologies as an adjunct to current public health practice, because it is every public health unit and the province actually do this on a daily basis as part of their work on infectious disease. And so whatever we have has to complement the work. It can't sort of probably replace the work. So I think these are some of the characteristics they'll be looking at. If it does make people's lives easier, it makes it more efficient, then that would be important. But some of these apps, as I know the characteristics, and because of privacy and everything else, some of them actually are voluntary. You enter your status, and then maybe other people will know that they are close to you. Just means that it's just another layer. It's not that every case perhaps could be traced using these apps. It's an adjunct. The other concerns are what it's like lab testing. It's sort of false positives where you just happen to maybe drive by, swing by, pass someone, and suddenly your phone goes bing. Those kind of characteristics is not what you want to have. And because that would alarm a whole bunch of people, they may then show up to be tested when in fact they were not at risk. So I think there's so many aspects of these apps that are still needed. But I think the bottom line, though, is the considerations of the people who are on the front lines of public health, who are doing contact tracing and whatever it is that would be helpful to them, I think.
So has Health Canada or the Public Health Agency done a rigorous survey of the apps and the various digital technologies that are in use now in some of the successful jurisdictions that have, put down their first waves of epidemic? Have you done a survey of those apps, and have you concluded what works well as even an adjunct?
No, that process is currently at play, and but it's not just health. Is in other government departments that's looking at innovation and applications as well.
Thank you. That concludes today's briefing. Merci.